Welcome everyone to our webinar on hairy cell leukemia. I will just stop sharing my screen so you can see our panelists for the introduction. So today we are here to discuss hairy cell leukemia and potential updates in the area. So for example, recently the British Society of Haematology have updated their guidelines, so I'm sure our panelists will refer to that. And I hope you find it a useful session. Rather than introduce panelists now, we'll introduce them as they speak, but just by way of introduction, for me, I'm Charlotte. I'm the Patient Advocacy Manager at Leukemia Care, and I will be chairing today's session. In terms of format, so we'll ask Chris to speak first, followed by Claire and Francesco providing a bit of a clinical background, and then we'll just move into a question and answer session. We have got a few questions that were submitted in advance, which I will pose to the panel. Please add any extra questions you can think of throughout any of the talks, and we'll come back to them at the end. And also, those of you watching on Facebook, we do have someone monitoring the comments and forwarding them on to me. So if you do have something you'd like to ask the panelists, please do pop it in the comments box under the live stream. Okay, so I think we should kick off now. I'd like to invite Chris to speak next. Chris is a hairy cell leukemia patient, and he's just going to provide a quick overview of his experience of since he was diagnosed with hairy cell leukemia for us. So Chris, take it away.
Thanks, Charlotte. Good afternoon, everyone. So yep, I was diagnosed with hairy cell in 2018, probably similar to a lot of other people. Just a routine blood test, basically for another condition. So I've been swimming in an open water lake, managed to scratch my foot, get an infection, and basically ended up with a pretty bad case of cellulitis. Obviously, as I now know, open water lakes are full of nasty bacteria. So after going to the doctors, they basically instantly referred me to the hospital, and I had intravenous antibiotics for about a week. So that made absolutely no difference whatsoever. And obviously, every time I went to hospital, I had my bloods taken, and there were lots of puzzled looks from the nurses and doctors, wondering why all of my blood counts looked so abnormal. So my cellulitis did eventually start to get better, but almost as soon as I stopped having the intravenous antibiotics, it basically returned, and I ended up with an abscess, which I needed an operation for. So I ended up in hospital for 4 days to have that drained. Again, basically lots of blood tests, lots of people looking at me, rather strangely, wondering why all my blood counts were rather odd. So basically, they let me go home from hospital, so that was great. And I really wasn't worried at this point in time until about a week later, and I had a phone call from the hospital I'd been in, from the haematology department. And they basically said to me, if you're thinking of going on holiday, strongly advise against it. And basically, if you get any sort of infection or you feel slightly unwell, take yourself off to hospital straight away. So I guess the alarm bell started ringing then, that something wasn't quite right. So not long after that, I had a CT scan, which was obviously to check my spleen, as I now know, and I had a bone marrow biopsy after that. And yeah, so basically 2 months after my initial infection, I was diagnosed with hairy cell. So I had no idea what leukemia was. You hear about it, but unless you're close to it. So I had no idea what leukemia was, let alone hairy cell. So obviously, like anybody else, being given a cancer diagnosis is like a bombshell. Being told you've got a rare cancer is even more worrying. But I was kind of pleasantly surprised to know that there was well-established chemotherapy drugs, which was encouraging. I was expecting them to be, you've got a rare cancer and there's no treatment. So I had to wait about 6 weeks until my foot had healed up before I was allowed the chemo, which was the standard week of Cladrabeen injections. So for me, the treatment was okay. I guess really the only side effects I had were fatigue, which is obviously very common, and an allergic reaction to one of the preventative medications that I had. So I found myself back in hospital again for a day for that. So of course, after treatment, your blood counts obviously hit rock bottom, and you end up, with no immune system whatsoever. So I was basically given a party bag. I think it was described as of preventative medications, and told to be kind of super careful for the next 3 months. I guess it's the equivalent of sort of self-isolating and then some. So I had weekly blood tests for a couple of months after the chemo, and gradually my blood counts came back to normal. And I was fortunate enough to be told I was in complete remission in May 2019. So I guess moving on from there, in terms of living with the challenges of HCL, I guess you can separate them into physical and mental. So for those of us that do have HCL, we obviously live with a much higher risk of infections due to our compromised immune system. So we have to be super careful of where we go, people we meet, and that was even before COVID came along. So I've adopted some sort of health strategies, probably common to lots of other cancers as well. So good nutrition, trying to eat healthily, plenty of exercise, which is obviously good for your health, good for your mental health as well, making sure I get enough sleep every day. So I guess I'm quite lucky that I lead a pretty normal life, and I don't really suffer from any side effects, although lots of people that I know in a Facebook group I'm part of suffer with things like joint and bone pain, long-term fatigue and aches, and vitamin D deficiencies as well. So I'm still having 6 monthly blood tests at the minute, so that kind of helps me understand where I am with my blood counts. So that can either be sort of reassuring or a constant source of worry, wondering whether your blood counts are good or bad, and waiting for the next test to see where you are. So that can be quite a tough sort of mental battle. As it's a chronic disease, obviously it's always in the back of your mind that it may return one day. So I find myself constantly sort of asking myself if I feel okay, or do I feel any different to last week. Although of course when I was diagnosed I was fit and healthy and had no symptoms whatsoever. So that's quite tough. I guess like lots of us, I've been working from home since March, not going into public areas or offices or anything like that. But obviously working from home can still have some own, its own sort of health worries. So both my children have been self-isolating at certain points, and my wife works in the healthcare system. So again, both of those sources could be bringing infections into the house. So and I guess lastly, in terms of sort of mental support, there's obviously lots of fantastic charities just like Leukemia Care that provide support for us and information, Facebook groups, online forums and things where we can share our thoughts and questions and advice with other hairy cell patients, and basically help with our own personal experiences to help other HCL patients deal with their diagnosis.
Thanks, Chris. That's a really great overview to kick us off. And a couple of points there I think I'd like to ask you a bit more detail on when we get to the question and answer later. Thank you for that. Sure. So our next speaker will be Dr. Claire Dearden. And I'm just going to share some slides for Claire to use. Claire, did you want to introduce yourself while I'm sorting out the technology?
Yes, good afternoon, everybody, and welcome to this webinar. My name's Claire Dearden. I'm a consultant haematologist at the Royal Marsden Hospital in London, and have been working on hairy cell leukemia for a very long time. It was my first project as a junior research fellow, was to look at the use of Pentastatin, which was then called deoxycofamicin. So I've got a long history with this disease and a great affection for it, because we've made such wonderful strides in terms of successful treatment. So if we could go to the, and that's that title, by the way, is a colleague of mine at the Marsden and I have just written a piece for the 60th anniversary edition of the British Journal of Haematology, which is really celebrating what has happened in haematology in the UK over the last 66 decades, since they've been publishing that. And we wrote this about hairy cell leukemia. So looking at the last 60 years, it's although there were descriptions of hairy cell leukemia by a number of people dating right back to the 1930s, it was really only a clear clinical description was first published in 1958 by a lady who worked at Ohio State in the United States. That was obviously hairy cell leukemia, including a very accurate description of what hairy cells looked like. But the term hairy cell leukemia didn't come into popular use until the 1960s, so almost a decade later. The first treatment that was ever used was splenectomy, and that was quite successful in the patients who responded to it. And interestingly, when I was first a consultant at the Royal Marsden, I took over the care of a patient who had had a splenectomy 27 years earlier and was still in remission. Subsequently went on to require treatment with purine analogues. So for some patients that was really helpful, but clearly for most patients it wasn't. The first systemic treatment was interferon, which was introduced in the early 1980s. And it induced good responses for patients, but not very many complete remissions. And typically when the interferon was stopped, patients would relapse quite quickly. So it wasn't a perfect answer, although it did ameliorate many of the problems with hairy cell, including the low blood counts. But later in the 1980s, and as I said, this was when I started to work on Pentastatin, which we received from the National Institute of Cancer in the United States. I used to get it by post. I'm sure it would never be allowed now. And we used to package it up and send it out to patients. And I accumulated a large cohort of patients who were treated at that time, some as their first treatment, but mostly for relapse after interferon with Pentastatin. And we were astonished because we didn't expect to see such amazing results. Virtually all the patients were responding to this treatment and their blood counts were going back to normal. And they were clearing the disease from the bone marrow. So it was thrilling. And this was followed very quickly by a trial that I was involved in using Cladrabeen, which was another purine analog developed really on the basis that purine analogs at that time were working very effectively. And we did the trial there and found that actually both of these agents worked well. There wasn't really any difference between them. And I'll show you some of our data from that. And we published the first of a series of long-term follow-ups of a large cohort of patients who'd received either of these drugs or both of them, showing that the remissions were very long-lasting. And I'll show you that as well. So the next big milestone, that kept us going for a good decade or more with successful treatment using purine analogs until the discovery in 2011 of the BRAF mutation, which is present in virtually all patients with classical. That was important from the view and understanding some that we see. But it was all
I lost the signal. Is it me only, or is it?
I think it might be Claire. Apologies, everybody. We'll just see if we can find out what's happened to her there. I thought it was me initially, but it appears Claire may have lost her connection. We will be back as soon as possible. Oh, here we go. She's joined us again.
Right, sorry. I don't know what happened there. I got disconnected from you, and I'm sorry.
That's all right.
So
Let me get back to where we were.
Yeah,
Apologies.
I'm just coming to the end of this slide on the history, and really to say that because they produced a drug for melanoma to target the BRAF gene, we were able to exploit that by using it in hairy cell leukemia with good effect. And since then, in the last 5 years particularly, we've had a number of new agents, which I'll come on to, and I think Francesco will be talking about. So if we could have the next slide, that's the historical overview. Just a little bit now about hairy cell leukemia itself. It's a rare leukemia, only about 2% of lymphoid leukemias, so CLL being the most common. Of all the leukemias, this has the highest male predominance, so 4 times as many males as females with this disease, and we don't completely understand why that is. People have done a number of studies to try and understand that without coming to firm conclusions. This is a younger age group disease than, say, CLL, so it's 2 decades younger than CLL as the median age in the mid-50s. And the presentation, which was shown you really by Chris earlier, is with pancytopenia, typically, which may just be picked up simply on a routine blood count. The splenomegaly is rarely symptomatic, but is usually detectable when patients are examined in the clinic. And again, looking back at Chris's experience, unusual infections are quite a common way in which patients present. And they're often unusual infections because of the loss of certain normal white blood cells that are important for fighting infections, such as monocytes. And so there may be typical bacterial infections like cellulitis, septicemia, but also they can be odd infections, respiratory infections. And that can make it difficult for people to make the diagnosis. And the other thing, again, that Chris mentioned that people on his Facebook have said is these odd other phenomena which can occur, including rashes, joint pains, bone pain, and can be challenging for patients and for making a diagnosis. However, once the diagnosis is entertained, provided people look carefully at the blood film, they're likely to be able to see in the top picture these very typical cells with the little hairy projections. They're quite unique. You don't see that in any other disease looking quite like that. And also these cells have a unique barcode, if you like. So when we put them through our machines in the laboratory for immunophenotyping, they come up with a profile, if you like, a barcode, which is quite different from a normal B cell or from another abnormal B cell, such as CLL or other lymphomas. So we can make the diagnosis very precisely with just a simple blood test, provided the cells are present. And so we don't need the BRAF mutation to make the diagnosis in most cases, although it can be useful where there's a little bit of uncertainty. But if we look for it, it is there. And of course, it may be important for therapy at a later point in time. What we know is that there's a variant hairy cell leukemia, misnamed really. It's not got much to do with hairy cell leukemia, other than the cells can sometimes have a few hairs distributed at one end or the other. But this is now classified quite separately from hairy cell leukemia that has the BRAF mutation. And these are the patients who perhaps present differently with a high white blood cell count. They still have monocytes. They don't have BRAF mutations. and they tend to respond less well to a single agent purine analog. We have helpful guidelines which are quite contemporary. So there was an international consensus guideline that we published in Blood in 2017 from the group of Hericene geeks, nerds, whatever, who meet together every year and discuss this fascinating disease. And we produced some guidelines in 2017. And as Francesco will go on to discuss, we've just updated the British Society Haematology guidelines in 2020. So next slide, please, Charlotte. And this is just to show you a publication in 1978. So this was 20 years after hairy cell leukemia had first been described, and about 10 years after it had been given a name, which looked at the overall survival for patients, which was a median of 4 years. And what I want you to contrast that with is the next panel, Charlotte, which is our series, which actually was published. This 250 patients were published a little while ago. We've now got almost 350 patients. But here, what we're looking at is an overall survival at 15 years, 78%, which is the same as an age-matched population. And if you look at the green line on top, where you've excluded deaths from other causes, if you don't die from something else, on that curve, you're going to live forever if you've got hairy cell leukemia, because patients are really only dying from other conditions. They're not dying from hairy cell leukemia. You can see a little fall off early on that curve, but then it becomes flat. And so overall survival at 15 years is 96% if you take out deaths from other causes. And we only have a handful of hairy cell leukemia related deaths in our series, and none of those in the last decade. So the other interesting thing is that patients who remain in complete remission at 5 years, their risk of relapsing after that reduces significantly down to about 25%, whereas up to 5 years, the relapse rate is about 50%. So next slide, please. And this is showing our results with both Pentastatin and Cladrabeen, just showing how similar they are, that there's no real difference between the two agents. They're both highly effective. We tend to use Cladrabeen now. It's rather easier to administer because you can give it as a subcutaneous injection, and it's more readily available now in Europe than Pentastatin. But what does make a difference is whether patients achieve a complete response or a partial response after that treatment, after that therapy. Overall, the median relapse-free survival is 16 years, but for patients who are in complete remission, it's over 20 years median relapse-free survival. So clearly our aim with treatment is to try and achieve a complete remission, because we think that benefits patients in terms of durability of the response. So next slide, please. And this is showing what happens to patients when they relapse. So as I said, about 50% of patients are likely to relapse, although that relapse rate falls off over time. But it's not a big surprise, I guess, that there's a law of diminishing returns if you keep using the same treatment. So if somebody gets first line, second line and third line Pentastatin or Cladrabeen, then the rate of complete remission will be falling off over that time. So patients will still have often respond, but their response may not be so good and it may not last as long. However, you can change that situation. So for example, if somebody had Pentastatin first line, didn't have a particularly good remission, and then second line they had Cladrabeen and they actually achieved a complete response with Cladrabeen, which hadn't been seen after Pentastatin, then they will still benefit from that as someone who is in complete response. So that's what you can see in the right-hand panel with the curves, is that whether you achieve whether the patient achieves a complete remission with first-line therapy or with second or subsequent line therapy, their relapse-free survival will be equally good. But what we were sort of postulating here was modeling, if you like, that if you only had purine analog treatments, then the median time to becoming refractory to the purine analog is about 34 years. So even given that patients, the median age is in the 50s, you're still likely to get to a very good age before becoming refractory to the current treatments that are available. So the next slide, please. If you can hold that picture in your mind of what happens first, second, third line using Cladrabeen or Pentastatin, in that fourth bar now, you can change that completely by adding something else. So here we've added rituximab to Cladrabeen or Pentastatin, and we've changed the natural history so that once we've given an additional drug and improved the response that's achieved, then patients now can be in very prolonged remission. So we have a number of patients where we can look at the curves on the right and show that following a purine analog alone, the duration of the response was not very long, or relatively speaking, for CLL, for hairy cell leukemia. But when you add rituximab, you can change that and get an extremely long remission. So I have patients who had several lines of treatment with monotherapy, Pentastatin or Cladrabeen, but now following combination treatment have had, decade or more of remission. So you can, and this is different from many other diseases that we treat, many other leukemias, we can change the natural history favorably by changing the treatment and giving something that works better. So in the BCSH guidelines, we do recommend a purine analog plus rituximab at relapse. And there is a good, there are a couple of trials now that have shown that giving rituximab together with Cladrabeen is superior as first-line therapy compared with either Cladrabeen alone or Cladrabeen followed by rituximab after a delay of, say, 6 months. Whether that's enough to change practice here is debatable, because we still see patients who do extraordinarily well just with monotherapy, and we can see that we can rescue the situation extremely well by adding rituximab at relapse. So next slide, please. So this is a drug that we started working on a number of years ago, again in collaboration with the National Cancer Institute in the US, with Bob Kreitman. And we this is an immunoconjugate which they have a big lab at the NIH which produces immunoconjugates. And here what you're doing is it's like an antibody, but you've put a payload with the antibody. So the antibody attaches to the antigen on the surface of the cell. In this case, CD22 was chosen. CD22 is expressed at very high levels on a hairy cell. So there's lots of potential for this agent to bind to it. And why CD22 was chosen is because it's got this quite clever property that once the antibody attaches to it, it sort of flips through the membrane. It does a 360-degree turn. And once it gets inside the cell, rather than sitting on the surface, it releases the payload. And in this case, the payload is a type of Pseudomonas toxin. And so that toxin is then released into the cell, and it's that toxin that kills the cell. And so it's very effective at delivering a very targeted treatment right at the cellular level. And it was found to be very effective in the early trials. And then we participated in an international study, phase 2 trial, which showed in multiply relapsed patients. So it was second and subsequent line of therapy, that we could achieve not just complete remissions that were durable, but MRD negative complete remissions, which were durable for 4 or more years. That trial led to the licensing of this drug for hairy cell leukemia. And it's actually the first drug that's ever been licensed specifically for hairy cell leukemia. And there's an ongoing study where this antibody has been added to rituximab to see whether responses can be improved. So this is an agent which we're waiting for licensing in Europe. We hope that that will actually be very soon. In fact, by early next year. And then we would hopefully be able to use it. At the moment, we still have some compassionate access to it. And we've treated a number of patients at Marsden successfully. So the next one, we're getting to the end now. So this was what I said about 2011, showing the BRAF mutations. I don't think you have to get too caught up with all the pictures on this slide, but just to show here the first patient that was treated, which was published in the New England Journal, showing the lines at the top, the very, very low blood counts that improved immediately after initiating treatment with vemurafenib. And that's a characteristic that we see with this inhibitor of the BRAF mutation, that the blood count responses are very rapid. So within days often, but certainly within the first 2 or 3 weeks, patients' blood counts will come back up to normal. And of course, it's the low blood counts that are the big risk for a patient with hairy cell leukemia. If you can improve the blood counts, then you can usually get a good clinical response quickly. So again, very exciting results with vemurafenib. And they went on to have 2 big trials. Next slide, please, Charlotte. Oh, I just wanted to show you this because I love this. It's something that Enrico Tiacci gave me these pictures. I'm very grateful to him. He was the one who published the first paper about BRAF. And that's a hairy cell all lit up, and you can see the beautiful hairs on it in fluorescent green. And you incubate that cell with vemurafenib, and hey, what happens? Next bit. It loses all its hairs. So I always think this is a bit like Samson and Delilah. You know, you've cut all the hair off this hairy cell and suddenly it implodes. Because the next step, Charlotte, is, if you press again, is that it dies. So this cell can't survive without its hairs. And it's interesting that the BRAF mutation is what is responsible for making it look like that, making it be a hairy cell. Next slide. So the Italians and the Americans did a couple of phase 2 studies, which were conducted separately, but were essentially doing the same thing. And they merged the results from the 2 studies to show that they achieved very high response rates. Here we see 96% overall response rate, CR rate of about 38%, which is not terribly high, similar sort of CR rate to what we've seen with moxetumomab Pasidotox. But what was perhaps the most disappointing thing about vemurafenib was the fact that these responses didn't last as long. You know, the median was about 18, 19 months longer for patients achieving complete remission. And I think if you press again the button, what's happened now is that we've seen with the addition of rituximab or obinutuzumab, you can achieve faster, deeper and more durable complete remissions. And we're just waiting for longer follow-up to see just how durable some of those remissions are. But there's no doubt that they've improved. And the next one is just to show we participated in a small study with the Germans, looking at patients that we had treated with vemurafenib on a lower dose than the standard 960 milligrams, which is the melanoma dose. And we found actually that we saw the same effectiveness in terms of response, with this very, very rapid rise in hemoglobin, neutrophils, platelets, so very good response in the first 2 weeks. So next, I think might be the last slide. Yeah, this is just to show one of my patients who got the 240 milligrams, and just showing really the clearance of the hairy cells from the bone marrow between September and February, so just over a 6-month period. All those brown cells in the bottom that are hairy cells disappearing, so mostly gone in December, but completely gone by February. So we were seeing these really nice responses. And the last slide, I think, is just to summarize that we see very high complete remission rates with purine analogues alone, probably even better with purine analog plus rituximab. These remissions are very long lasting, particularly if patients achieve complete response. And we still have very effective therapy for patients who relapse, either by combining purine analog with rituximab or using a novel therapy such as moxetumomab, vemurafenib. Ibrutinib I didn't really mention. It is effective in this disease, but probably less so than some of the other drugs that we've been using. But I think the take-home message for patients out there is that we've got a series now of about 350 patients, and our survival in that series is the same as an age-matched population. So, you know, people are, with this diagnosis, are looking at a normal life expectancy, but also hopefully a normal quality of life as well. So thank you. I'm happy to take questions when we get to that point.
Thank you, Claire. That was a really great overview of from 1950 till now.
Technical glitch.
That's fine. I think it's expected in this modern age of working from your back living room or whatever it is we are. So our next speaker is Dr. Francesco Falcone, and he's going to complement Claire's discussion with a bit of an update on what this means for clinical practice, I guess. So Francesco, do you want to introduce yourself and then let me know when you're ready for the next slide?
So hello everybody, thank you to the Leukemia Care for inviting me to give this brief update of the new BSH guidelines written amongst others with Nilma and with Claire. My task today is, yes, to give a brief update on the BSH guided treatment and care. So if we could go to the first slide, to the next. So before we get into that, to complement a little bit with what Claire had presented, just to remind everyone that hairy cell leukemia is a B-cell malignancy derived from mature B cells at some peculiar time of the process following antigen engagement. This normally happens in the germinal center, in the lymph nodes. Hairy cell leukemia is not a disease of the lymph nodes. It is a disease of the spleen and bone marrow. And mind you, it actually spares the classical sites of antigen engagement in a place that is called the germinal center. This is quite an important pathological observation in an era where we move away from the classical eye-based observation of what disease is. And I'm saying that with strength, because all the things that I've learned from hairy cell leukemia, the majority of the things that I've learned about hairy cell leukemias have come from the UK while I was doing my PhD there, and very much from the work developed at Royal Marsden by Katowski and then Claire Dearden for such an important and long time. And as much it is important to stress this, because the morphology of the cell that is somehow in between a B cell and something that looks like a dendritic cells, a macrophage, a monocyte, has strong implications for future investigations in hairy cell leukemia, because if there is a problem with hairy cell leukemia is actually with the current treatments in the very first phase of the treatment, when infection is the major issue. And infections, when Cladrabeen was started and was given intravenously for 7 continuous days, could bring to a mortality of up to 25%. So the fact that there is a severe immune suppression, and this might be the effect of lack of macrophages, impairment of monocyte differentiation, of the key elements protecting from the first phase of immunity, of infection, the first barrier of immunity, is quite an important aspect to further develop. Going further, next slide. So this is just a summary of where the origin of the cell is being sought. This is some work done with the group in Switzerland on epigenetic profile of the hairy cells compared to normal B-cell subsets. And this suggests that hairy cell leukemia derives from a cell of the marginal zone likely, or at least similar to the marginal zone. So again, outside what is the classical germinal center. Next slide. So I think Claire has already touched many of these parts, but it is my task to reinforce what Claire had just said. So hairy cell leukemia is a disease of the working age with a huge prevalence on the male population, and this is not known why there is such a distribution towards the male individuals. It is actually a diagnostic hint when we see from other centers and when we receive other information where female individuals are suspected hairy cell leukemia, and the first thing that you want to worry about is that it's not another marginal zone-like condition. But where the morphology is very much that of pale, medium-sized lymphocytes with these hairy projections. The hairy projections are as much pathogenetic, as much as making a little comment towards that publication that Claire highlighted, where the addition of BRAF inhibitors removes the projections. Well, it's important to state it is not something related to that specific gene. It is something that is related to the fact that the inhibitors of the several pathways, including those of the B-cell receptor, do cause in any type of cells a shrinkage of the cell. This is something that happens also with ibrutinib or PI3 kinase inhibitors. So a shrinkage of the cell where obviously you will lose any form of projection that are also naturally present in the B cell. This happens, for example, with ibrutinib in CLL. Where there are not much villi, but that those little projections that can be seen at microscopic level do get rid by inhibition of the B-cell receptor pathway. So having got into this biological introduction to link with Claire's presentation, the next slide. So hairy cell leukemia and its classification has had some form of evolution through the WHO classification in 2008, and more recently in 2016. I have a child who's interrupting me. Sorry. In 2016, with the review of the was interrupted with the WHO classification that importantly distinguishes hairy cell leukemia from other variant subtypes, namely what was called the hairy cell leukemia variant, that is indeed within a different chapter, hence the need of a classification that distinguishes hairy cell leukemia from other types of splenic lymphomas. Next slide. So Claire mentioned an important revision of the guidelines for the diagnosis and management of hairy cell leukemia, led by Mike Grever, but where all those people interested, all those doctors interested in hairy cell leukemia across the world have joined. And within this effort, there has been a revision of some consensus guideline that was defined in 1989, I think, at an earlier conference, and then left behind for the short development of new therapies that we now see having a revamp of the presence of novel therapy, and so bringing us to have a new classification, a new guidelines that have brought the UK to write their guidelines and update what has been done by the Hairy Cell Leukemia Foundation, International Hairy Cell Leukemia Foundation. Next slide. Next slide. Led by Nilima Parry-Jones for the diagnosis and management of both hairy cell leukemia and hairy cell leukemia variant. So next slide. So what is the presentation of hairy cell leukemia? Again, this was mentioned already by Claire, but what is relevant to notice is the clinical presentation is generally the same. We tend to have individuals that for some reason have a blood test and some form of cytopenia is documented. And following that, an examination by a specialist will reveal in a large proportion of the individuals a splenomegaly. The splenomegaly that we see around here reported as 60–70% is actually likely the combination of also the revisions with imaging techniques, including computed tomography, because more recently, given the opportunity of a more refined diagnosis, even when the pancytopenias are not as important, the objective of documentation of splenomegaly is not as frequent. But together with the cytopenia and with the splenomegaly, there will be the important finding mentioned before of an absolute monocytopenia, so a reduction in numbers, if not an absolute lack of a type of white blood cells called monocytes. The hairy cells in the peripheral blood may and may not be there. There will be some shedding of hairy cells if we look at them with careful eye, but we will find the hairy cells mainly in the bone marrow, next slide, and in the spleen. Now, I like to show this picture of hairy cells, which is not original at all. It is one of the most common slides, sometimes borrowed, some other times stolen from the Royal Marsden Hospital, I think. I don't know if this was made by Claire or by anyone in the team, but that actually represents some degree of variability of hairy cells and how difficult it is to distinguish in some occasions variant forms from classical hairy cell leukemia. In these 4 slides, there was an indication of which was the variant and which was the form, but there might be some variations in the shape of the nucleus that can be oval or that can be bean-shaped, while the projections must be there. This will require then within the guidelines, in order to have an initial evaluation, a bone marrow biopsy associated with an immunophenotype, with immunohistochemistry, and where there is need for a splenectomy that is currently avoided for the diagnosis, and that might be considered in specific options when first or second line treatments are not sufficient, or when a revision of the diagnosis is required following initial treatment. It can also be defined by histology of the spleen. The most recent investigations have instead brought us to define hairy cell leukemia at molecular basis, but I reinforce the information of Claire that actually phenotype and morphology may per se suffice the diagnosis. It is when the phenotype and the morphology cannot be sufficient, a molecular diagnostic test with the BRAF, with the search of BRAF mutation, in those cases, it is very much required. I'm saying this because not all centers yet can have the BRAF mutation test available. Next slide. So that the conclusion is that the approach to the diagnosis of hairy cell leukemia is really multiparametric. It relies on peripheral blood morphology, on bone marrow biopsy, and again, here there is some work, recent work. When we say recent in hairy cell leukemia, we are talking about the last 10 years, as research moves slowly on the phenotypic characteristics of the hairy cells with expression of particular molecules like ANXA1 on top of the most commonly known molecule, molecular characterization of BRAF mutation, but certainly the phenotype with expression of activation markers that include not only CD25, but also a marker like CD200. This is quite useful to complete the diagnosis. So next slide. I apologize again. 3 adolescents came back from school and started doing their things. So this is an example of how the diagnosis of hairy cell leukemia has reached a different approach by analysis of the BRAF mutation by an allele-specific PCR. This is the work that we did with Enrico Tiacci when I was in Italy, but now it's simpler for those centers that benefit from a Doppler, from a droplet PCR, so that it is possible to detect minimal amounts of mutations where there is either a suspect of hairy cell leukemia or where there is an intention of monitoring the disease by molecular tools. The monitoring of the disease by molecular tools is not a diagnostic approach, but it has strong implications where, with the advent of novel molecules, there is an intention for research purposes to investigate the potentials of the novel drugs to eradicate to eradicate the disease and obtain a negativity of the minimal residual disease. Next slide. So this is what is represented on the Hericene leukemia guidelines just published in October, where the differential diagnosis is really required between Hericene leukemia variant, and mainly splenic marginal zone lymphoma. I avoid this form of splenic red pulp lymphoma, which is an extremely rare condition, and where at the end, the only way to make a diagnosis is through a splenectomy. And where actually, given the rarity, doesn't help much. At that stage, it would be also clear that it wouldn't be about Hericene leukemia. Doesn't help much in making a differential differential choice of treatment between a variant or another splenic marginal zone lymphoma. So anyway, to summarize the important points of Hericene leukemia for a differential diagnosis, we mentioned is the gender, heavily prevalent in the male population. Age, it is a working age, while the variant forms are in a more advanced stage, as much as the splenic marginal zone lymphoma. A typical immunophenotype, it may require the addition of some markers. In the UK, it's very important to consider CD1, 2, 3. But certainly markers like CD1, cyclin D1 is important versus the classification from other conditions other than mantle cell lymphoma. And very much the marrow involvement with a fried eye pattern with a minor intrasinusoidal component and marked fibrosis are very much features of Hericene leukemia. Should a splenectomy be made, a key aspect, very much different from all the other forms of marginal lymphomas, is the atrophy of the white pulp. We don't know why that happens, but that is quite an important characteristic. And certainly the presence of BRAF mutation is important and conclusive complementation to the rest of the information. Next slide. So what is the staging and treatment approach? In first line, you heard from Claire how Cladrabeen can make, or another purine analog like desoxycofomicin will make patients with Hericene leukemia immortal, given the fact that if you exclude any other cause of diagnosis, you will find out that patients with Hericene leukemia will not die of Hericene leukemia, except again for the risk of infection in the first phase. Now, this is something that is hard to highlight in any guidelines, but I think the experience of many of us and the transmitted experience from other centers is, however, that although there are clear indications on when we must start treatment for Hericene leukemia, and I will go through this, it is also as important to comment on the fact that probably if we give the treatment earlier than when required, there will be an advantage of avoiding the risk of complication by the immunosuppressive effect of purine analogs. So certainly indications for treatment are when there is a severe anemia. It's been mentioned as a cutoff of 11 grams per deciliter, or there is a platelet counts below 100, or the neutrophil counts below 1000. But again, it's not to be discouraged to start a treatment earlier to avoid the complications of the treatment with first-line purine analogs. at the time when we think that we will want to have to start treatment, it's important to restage the patient, certainly with a full blood count and morphology. And I will explain here why the full blood count is important. It is now common and advised to have also a CT scan to properly measure the spleen size, but most importantly to exclude unexpected lymph node masses and have a degree of information from the bone marrow biopsy trefine of the infiltration of the hairy cells in the marrow prior to starting purine analog therapy. So why is it important to have a clear documentation of the full blood counts? Unfortunately, for hairy cell leukemia, being a very rare condition, it's very hard to have studies that will be able to confirm on large scale the predictive or prognostic effect of certain parameters. But in the large cohort from the Royal Marsden, it's been documented clearly how the starting level of platelets and of hemoglobin have an important prognostic parameter in terms of progression of disease following purine analogs that adds on the quality of response. So an individual with a complete remission who started with low hemoglobin and platelet levels is expected to have a duration of the response shorter than individuals who have a normal hemoglobin and platelet level. So next slide. So I think I can cut the story short here by mentioning how all the evidence has been presented in her previous presentation by Claire, how the first line treatment is a purine analog, depending on what the consultant, the doctor, is accustomed to. Now Cladrabeen has been taking place because probably it's more practical, short duration, 5 days, that could be given as a day hospital for 1 week, and then it is a matter of monitoring the complications of the treatment, as opposed to Pentastatin that is given in fortnightly doses with regular review of the effect of the treatment, particularly on the suppression. Next slide. Next slide. And again, no, the previous one. Previous slide. Yeah. And again, here it is important to remark how, again, I'm redundant in presenting the work from the Royal Marsden, but how whatever the type of treatment, Cladrabeen or Pentastatin, is given, the overall survival for the patients who receive the treatment in first line is very much similar or superior, inverted commas, to the normal population, with very, very few individuals relapsing, dying for hairy cell leukemia. It is expected, however, that patients, depending on response and tumor burden before treatment, that will relapse. Next slide. So the assessment of the response to see what the quality, what the amount of tumor cells that have been eliminated has been, is important. There are conditions like, for example, chronic lymphocytic leukemia, the most common form of leukemia, where it is now debated where we really need to assess a bone marrow the response with a bone marrow biopsy. There are very important streams of line, one reporting, one suggesting not to do the bone marrow biopsies, another one where it is required to do a minimal residual disease assessment. Well, in hairy cell leukemia, it is important instead that it is important to consider the time. The time when we want to assess a response is around the 6 months from completion of the treatment, because there is a long lag from time of end of treatment to when the bone marrow will recover and the cells will die. So the next slide. So the treatment of relapsed and refractory classical hairy cell leukemia is, again, can be simple purine analogs, and it's important to consider the time from when this treatment is, from the first line of treatment. Otherwise, the addition of rituximab has been again shown by Claire. Next slide. This is what's been published so far, but now there is the work from Claire. There is an update shown in the previous presentation by Claire, and there is the work by Kreitman in JCO, showing how the addition of purine analogs leads to a very prolonged duration of the response, if not, in many cases, eradication by conventional tools, analysis of the disease. So it is a matter of choosing whether rituximab should be given to the purine together with the purine analogs together or as sequential. And I invite you to review the proposal by Kreitman that's just been published. Next slide. Or the other possibility is experimental approaches. Now, the BRAF inhibitors are indeed the paradigm for the experimental approaches. This is the work that's been presented by Claire and published by Enrico Tiacci, also together with the New York team, Tolman, where there is clearly an effect of vemurafenib targeting the BRAF mutation on hairy cell leukemia. It remains that on these grounds, there will be a lot of work to be done. The main reason being, as we know, one, that yet we do not know what the exact dose is. Again, you have had the presentation, you have had clarified by Claire in her previous presentation how reducing the dose may have the same effect. The problem that we are facing is that we are looking at this information from very small cohorts. The second aspect is that vemurafenib will work without eradicating the hairy cell leukemia clone, despite the BRAF mutation being a totally clonal mutation, so that it acts in a way to old style interferon, if we may be allowed this paradigm, so that if you stop vemurafenib, the expectation is that the hairy cell leukemia clone will come back, as opposed to what happens with Cladrabeen or Pentastatin, where the effect is quite prolonged and may be reconsidered on second and third line. I won't comment for other opportunities like ibrutinib that has some effects, but again, this was investigated in a study of, I don't think, a huge number of individuals, and closed. The study was closed after a short duration of follow-up. One reason also being that the PI decided to go to work in a commercial company, but there is some effect. And it is again an important thing to consider that both ibrutinib and BRAF inhibitors work on similar pathways where one can operate over the other. In short terms, we know, for example, that ibrutinib and venetoclax, which is a completely different drug, work well together because ibrutinib operates by suppressing some molecules like MCL1, so that the effect of venetoclax will be more potent. It will be interesting to see how combinations on vemurafenib will work for the same reasons, so that the targeting of one molecule will be more effective by suppressing the antagonizing effect of other kinases. So I think I can stop here, even if because I've gone too long.
Thank you.
But I will like just to scroll through it to see whether I have missed some pieces of information related to the guidelines. I've mentioned moxetumomab. I would like to leave things about trametinib, but the important bit that I would like just to mention, a bit more tricky, the information about hairy cell leukemia variant, because we do not have a clear standard, but certainly the single agent approach with Cladrabeen or Pentastatin is insufficient. So polychemotherapy approaches, or the association with rituximab at least, or potentially novel agents like the anti-CD22 conjugated toxin might be certainly something to consider. Ibrutinib might be something to consider, as long as the variant form is not associated with multiple genetic associations. And I think I would like to stop there for any questions.
Perfect. Thank you, Francesco. Let's do a whirlwind question session then with all our panelists. I've had this question in the back of my mind, and it's still sort of something that I think would be relevant despite all three of your talks being really good, is just to pose what you guys think the biggest challenge remains is, I guess, for hairy cell leukemia. So maybe I'll start with Claire, if that's okay, and then we'll go Chris and Francesco. Just very quickly, what you guys see as sort of the biggest remaining challenge for hairy cell patients.
Yes, I think there are three things that I'd probably mention. One is patients presenting with serious infections, particularly at diagnosis, but also sometimes with relapse disease, and managing those infections appropriately and carefully before initiating treatment for hairy cell leukemia, and what treatments you can initiate safely in the context of somebody who has an active infection. So that's something we still think hard about. And of course, we're thinking again about this in the context of COVID at the moment, and what we should be recommending as a safe treatment for patients presenting at this time. The second thing, of course, is patients who have, it's only a small number of patients, but there is a group of patients who have very short remissions, multiple relapses, and quickly become refractory. And because some of these patients are quite young, then they're not going to have that 30 years plus of being able to have consecutive purine analog treatment. And again, it's having the right interventions at that time to change the natural history of the disease. Mm-hmm. And then the third thing is the unusual manifestations that patients get. So there are a lot of symptoms that patients are getting that we don't completely understand. I think we will get a better handle on all of this when we can merge data. You know, we've got quite a big cohort and have collected data, but what we need is not hundreds of patients, but thousands or even tens of thousands of patients with a rare disease who get a rare complication in order to get information about it. So we're building up this international registry where we're trying to collect data on patients, including some of these unusual manifestations, something like focal bone disease, for example. I do see a number of patients with this as a complication. It's rare, but it's quite debilitating. So it provides, it gives patients far more symptoms than most of the manifestations of hairy cell leukemia. So it's things like that that we don't yet fully understand and haven't really got to grips with properly.
Yeah. And Chris, I think the last thing Claire mentioned there is of particular interest to patients, perhaps, are things, the long-lasting impacts, the side effects, those sorts of things. Is you're an active member on Facebook groups, you said, is that the sort of thing that patients would like to see addressed? Is that the biggest challenge, do you think?
Yeah, I think so, Charlotte. I think, as you say, on the Facebook group that I'm part of, I mean, there's only 1,000 of us, and obviously Facebook's global. So, but yeah, I think those sort of things, as you say, like bone and joint pain, fatigue, and aches and pains, it's very hard to know whether that's associated with the hairy cell or whether that's just normal, as it were. So yeah, I think that's definitely one of the challenges. I guess probably another one is we're always worried about our blood results, so we're always kind of 6 monthly waiting. If there was a way to be able to, I wouldn't say instantly, but kind of like a COVID test, to be able to take a quick blood test to kind of know whether you're white and your red blood cells and your platelets were right, and you were just it's just your mind playing tricks on you, would be great.
I was gonna, sorry, Francesco, I'll come to you in a moment, but I was actually going to pick up on the fear of relapse thing. How do you cope day to day with that back of your mind feeling about you're in remission, you're well, but you technically still have leukemia? How do you cope with that day to day?
Yeah, it's quite difficult. I guess like everybody, you have good days where I'm in remission and everything's great, and then obviously other days where your mind wanders and says, well, I must still have this, because there's obviously a chance that it can, as you say, that you can relapse. I guess online forums, things like this, the things that Claire has said today in terms of the statistics of people and the rates of remission. If you're still in remission after 5 years, your chances of relapse. I think everyone's very scared when they have a cancer diagnosis. So being able to see some statistics like that have been built up over a long period of time is probably very comforting to people. Certainly on an initial diagnosis. But yeah, it's an ongoing mental battle.
Yeah, I'm sure it is. Yeah. And then Francesco, is there anything you wanted to add to what Claire and Chris said there about the remaining challenges for hairy cell leukemia?
Well, I think that from my standpoint, I would like to merge what Claire and what Chris has mentioned. So at the end, this is a condition of which we do not know the origin. There are a lot of uncertainties on why it develops and how it develops. The presence of a genetic mutation is insufficient per se to justify many of the aspects, including the morphology of the cells. There is work that has addressed that, but it is insufficient. It doesn't explain it really. So we also know from what Chris was saying that at the end, I feel uncomfortable of using the word relapsing as opposed to recurring. So we do know that the disease cannot be eradicated. So it is a huge, massive psychological effort on the individual who's in his working age with a family. Children, as you can expect, in some family it might be more demanding than in others who get into your life while you're working at any moment if there is a COVID and interrupt your presentations. So the demand of an individual who has this psychological heavy problem, knowing that likely they will receive a second line of treatment, is quite burdening. So it is not only understanding why the condition relapses, but it's very much why the condition remains there and how we could challenge it.
Yeah.
And there is a huge effort through this repository in which I think certainly the Royal Marsden and Southampton is also participating in order to collate all the pieces of information and direct the research, and possibly collate also the material on which to do the research.
Yeah. I have another question for you, Francesco. Just in sort of relation to what you said at the beginning of your talk around diagnosing hairy cell, and it seemed to be that over time it's got more and more complicated with all those markers you've talked about being identified, and how we're now looking less under the microscope and more at genetics. Do you see that getting more and more complicated? We've seen that in other leukemias where you sort of divided up smaller and smaller into groups of patients that are distinct from each other. Do you see that happening further in hairy cell leukemia?
So, in general, there has been a tendency of over-sophistication of the diagnosis, removing the role of the expert consultant. I think I've said it in other presentations, but the model in which I was grown in hematology is where first you see the patient, then you look at the morphology of the cells, and that was very much the remit of potentially one single individual, and that made things very, very cheap. Hairy cell leukemia is very close to that. Certainly there are parameters, there are abnormalities, there are characteristics that are atypical in some circumstances, and there additional genetic requirements and investigations are certainly useful. In general, for hairy cell leukemia, the BRAF mutation is quite a dominant characteristic, so the addition of that is at least no harm. I wouldn't consider it as a exclusive characteristic of hairy cell leukemia. And I think that not only the public, but also the general hematology community still needs to be re-educated in refining the profile, the diagnostic profile. So the answer at the end is no.
Thank you for that. That's interesting. I'm trying to remember what my next question was. Apologies. Claire, my next question was to you. I've seen quite a few people say, give an example of their symptoms that they still have, and they send us up their blood counts and said to us, why am I still having these symptoms? So why do people who have ordinary blood counts appear to be in remission? Why are they still suffering with bone pain, fatigue, just to give a few of the examples that we've heard since we announced the webinar?
That's a very good question, and I wish I had a good answer for you. I think some of the bone pain, if there's sort of mechanical damage to the bone, that doesn't necessarily repair completely, even when the hairy cell leukemia has gone into a good remission. Happily, often it does. So patients feel much less symptomatic when they've had a good remission, but it's not always the case. And you can imagine that if you developed a bit of a hole in one of the bones, then that could still cause some discomfort. The fatigue is really difficult. I mean, fatigue is the commonest symptom that anybody has ever. I mean, if you work in a routine laboratory, when you get a blood count from the GP, the typical request on it says TAT, which tired all the time. TATT, and that's because most people are going to their GPs, and this is not hairy cell leukemia, but most people go to their GPs, they're tired all the time, and so we get blood counts because of that. So it's a really hard symptom to pin down, and it will be linked so much to other things, people's lifestyles, people's state of, how emotionally upset they are by things, how much sleep they're getting. There are very, very many factors. It's not that the fatigue isn't there, but it's very hard to determine why it's there.
Yeah.
And there's been a lot written about cancer fatigue. So cancer, it's a very common symptom in other cancers as well. And the usual sort of dogma is you know, with this sort of fatigue, the best thing is to get up and do things. The more active you are mentally and physically, the less likely you are to have persistent fatigue. It's not something that is wrong with your body, if you like, in the sense of your heart not working properly or being anemic, so that the blood isn't carrying enough oxygen. So actually lying down on the bed and resting is not always helpful. It can actually make the fatigue worse. So the best thing, I think, you know, what we've found has helped patients most is to get some sort of program going with a bit more exercise, all the things that Chris says. He's concentrating on his diet, he's concentrating on getting good sleep, he's concentrating on all of those good health initiatives. And I think that can, you know, bring about improvement in fatigue, certainly. But I don't have a perfect answer for why patients get that. I think over time, it goes. And I think, Chris, one thing I'd say to you is that as time goes on, you'll feel less anxious about those blood tests. I mean, that's our experience, is that, you know, it becomes, much less of an event. It just slots in as part of normal life.
Hopefully, yeah. And anybody who's interested in further information on dealing with fatigue, we did a webinar on that very recently, which you can find on YouTube.
Like my dog.
The dog has an opinion.
Somebody.
So my next question was a very quick one to Francesco. So we've had a couple of people asking why their blood counts go up and down over time, or why they always seem to be on the lower limit of normal, why they can't seem to get themselves into the perfect blood count range. Is that normal for patients to see a bit of variation over time?
So I assume we're talking in the context of patients who have received treatments for Hericene leukemia.
They haven't specified, but yeah, I think that'd be a reasonable assumption to make.
Well, in general, in the normal population, as we all know, there are big ranges of variation within normality, and that is part of the physiology. We easily gain weight and lose weight to some extent, depending on the fact on our standards. Many people gain weight by staying at home because of the COVID. So the same do the most sophisticated blood tests, and things change. They change with the diet. As long as they are within the physiological variations, it's a normality, and it's hard to explain why. Within the context of Hericene leukemia, we do know that the first phase of treatment, the diagnosis, is associated with two factors that may cause the drop of the values down. One is certainly the tumor burden. Second is the cytokines that the tumor cells release, and those cytokines do affect the normal production of red blood cells, platelets, and white blood cells. Following the treatment, we must remember instead that quite often the treatment is a chemotherapeutic agent, and these agents are throwing a bomb in a field of flower during spring. So it requires the next spring to have those flowers to regrow. It's not a targeted treatment, and it does require a long time for the marrow to recover. This links me to the reason why quite often individuals may see their Hericene leukemia having a much better response if they assess their bone marrow 3 months from end of treatment to 1 year from end of treatment. Because there is a combination of the cells that are dying off, of the tumor cells that are dying off, the toxicity of the marrow, and the recovery of part of the marrow. Part may not regrow. So these are the many different situations in which we may find ourselves or the patient with a Hericene leukemia.
Great, thank you, Francesco. And if anybody's got any sort of concerns about their own health, please go speak to your own team in relation to blood counts, or all the questions we had in relation to side effects or remaining symptoms and things. I hope Francesco and Claire's answers have been reassuring, but if you have any outstanding questions, please do seek further help on that. And Chris, I wanted to give you the sort of last word, if you like, for our webinar this evening. My question, I guess, is if someone today is listening and there may be only a couple of months into their journey so far, not everybody likes the word journey, but I'll use it in this context. What do you have like something you'd say to them to sort of give them hope for the next several years, if Claire is correct in terms of how successful treatments are?
Yeah, sure. Yeah, obviously the data that Francesco and Claire have all provided, statistics show that a lot of people can make a good remission with the first line treatments. And yeah, go and join some online forums or some groups or whatever your favorite social platform is, because there's lots of other people out there just like us that are going through the same thing. And I think a problem that's shared between other people, I reached out to Leukemia Care, and you see the information that's out there just kind of helps you sort of put things in perspective.
Great, thank you so much for that, and thank you to all our panelists this evening. I've just got a couple of remaining slides to share about general information about Leukemia Care that may be of assistance to everybody. We are slightly over time, so I apologise for that. Go back one. So just to remind you that we've got lots of sources of information, and you'll get a link afterwards if you wanted to sign up to our newsletter to remind you of all of these. And lots of support services, many of which we can provide digitally, which is really important in the COVID-19 era. So, which we've managed to avoid talking about today miraculously, largely. So that's a positive. Please do get in touch if you do need further support. Here are our contact details, which I'll leave up just for a moment, but you can go back to our YouTube channel to capture anything from today's webinar. Just to say thank you to Hericene Leukemia Foundation for promoting this webinar for us, as well as Chris in the Facebook groups, and also just to mention there are other charities such as Blood Cancer UK who can provide support for you. And that's the end of my slideshow. All that remains to say is another thank you very much to our panelists today. You've been fantastic, dealing with many challenges, dogs, children, technology. It's been fantastic to have you. It's very difficult to work from home. I really appreciate your time, and I hope everybody has a wonderful evening. Thanks, guys.
Thank you all.
Bye.
Thank you.
Bye-bye.